Good evening, delegates and participants. Thank you for joining Shield Connect. Today we have a doctor from Manargudi, and ma'am is going to speak on recent advances in PCOS. And the speaker for the day is Dr. Surya. Ma'am has done DGO, DRM, DMAS, and ma'am has done diploma in reproductive medicine from Germany. And ma'am is consultant in Tamil Nadu Hospital from Manargudi. So before we start with this session, let me give a little introduction of our page, shieldconnect.in. So you can go through this page and you can find various sections are available. The first section is the blog section where you can find various blogs are available. Then we have a webinar page where you can find all the upcoming webinars. And we also have our leader section. So you can check detailed profile of our speakers who are connected with Shield Connect. So today's topic, I will hand over the session to Dr. Surya, and I welcome ma'am on our platform for today's webinar. Thank you, ma'am.
Thank you. Thank you so much. Is the screen visible?
Yes, ma'am.
Hello.
Yes,
Yeah.
Your screens are visible.
Yeah. Good evening. I'll just start with the topic. Coming to this, beforehand, I just thank Shield representatives and the managers for giving me this wonderful opportunity. I have previously did one webinar for them, and this is my second chance. I sincerely thanks to them for giving me this wonderful activity. And coming to the topic proper, it's recent advances in PCOS. We all know that PCOS is something which we learn each and every day a new thing. So the certain interleukins or certain growth factors or something which we want to know the entire thing, because so many molecular development on the basis of its epigenetics, basis of its interleukin levels of being upgraded, and they are for day by day, it's just a growing topic. So we can learn a lot of newer things in this field, and of course we can research, we can update our knowledge when we go through a lot of articles. So I'm just very much glad to share a few points on the recent advances. So it's a complex endocrine condition affecting the women in the reproductive age group, with the prevalence being 15 to 20%. Increasing evidence suggesting that PCOS affects the whole life of a woman. It can begin in utero in genetically predisposed subjects. It's manifests clinically at puberty, continues during the reproductive years. Major cause of anovulatory infertility, and diagnosis is generally based on the criteria of Eshrey and ASRM Rotterdam criteria, which is very well known to everyone. Coming to the introduction part, we can classify into genetic, metabolic, endocrine, and environmental abnormalities. In the clinical features, we all know that it includes hirsutism, acne, male pattern baldness, and acanthosis nigricans. So the PCOS can expose the patients to increased risk of cardiovascular disease and various metabolic complications that include diabetes, especially after menopause, or during the fertile period itself. It may cause anovulatory infertility, and sometimes if the mother is pregnant, it may include miscarriage, gestational diabetes, and preeclampsia. Coming to the ETA pathogenesis and the epigenetics of PCOS, it all contributes. It starts it starts from the fetal life itself. Coming to the prenatal or prepubertal hyperandrogenism, and also it plays an important role in growing insulin resistance. That is the key factor in causing an ovulation in PCOD. So if we see the genes regulating the insulin, we all know there is something called leptin and adiponectin. Basically, these leptin and adiponectin are very important in regulating the hormonal levels of PCOS. Leptin is something which regulates our eating pattern. If leptin resistance or insulin resistance happens, definitely there would be a how to say, if insulin resistance happens, means there won't be any good metabolic derangements or metabolic arrangements in achieving a proper ovulation. So ultimately land up in anovulation. So any alteration in folliculogenesis or steroidogenesis definitely will land up in anovulation. So there are various studies that suggest a link between the fetal growth restriction and subsequent risk of type 2 diabetes mellitus and cardiovascular disease. The increased risk of these metabolic diseases has been linked to elevated insulin resistance in young individuals, which are exposed to an adverse in utero environment and born small for gestational age. Studies support an overall relationship between fetal growth restriction and increased adiposity and insulin resistance starting early in the childhood period. So, coming to the endocrine factors which affect the ovulation, this ovarian folliculogenesis is regulated by a delicate equilibrium between extra and intra-ovarian factors. So, the disturbance of the equilibrium may alter and compromise the follicular development and formation of the mature oocytes, ultimately land up in infertility. So, what are all the extra ovarian factors that attribute to the causation of an ovulation? So, it includes a series of endocrine, paracrine, and metabolic alterations, which by causing abnormalities in the follicular microenvironment may also alter the folliculogenesis and the oocyte development. These alterations include FSH deficit, hypersecretion of LH, and hyperandrogenism. So, if the folliculogenesis and oogenesis also depend upon the intra-ovarian factors, especially the follicular fluid factors, which are directly correlated with their levels in the plasma. So, there are various theories that states that the cytokine and inhibin levels and the interleukin levels, these are all multiple things that contribute to the development of pathophysiology of PCOS. If you see various extra ovarian factors such as hormonal factors, and if you ask for any intra-ovarian factors, that includes various cytokines, the hormones ultimately land up in oxidative stress, and definitely that will lead to the poor embryo quality formation. A high percentage, that is 55 to 75% of women with PCOS have an elevated LH-FSH ratio. Not only increased LH-FSH ratio, they also have increased insulin levels, that is insulin resistance happens. So coming to the estradiol levels, that could be either normal or increased. Coming to the FSH level, that could be either normal or increased. When you see to the follicular growth in their patients, generally what happens is that would be many preandral follicles, which are of developmental size 6 to 8 mm, which won't increase after that size. So it remains at the size of 6 to 8 mm at the preandral stage. So it contributes to the formation of a necklace-like pattern when you do an ultrasound. So generally, PCOS patients having increased LH and FSH concentration when compared to the normal patients. So this hypersecretion of LH in PCOS, which will contribute to the luteinization of the granulosa cells, that contribute to the arrest of the follicular stage, that ultimately land up in formation of polycystic ovarian disease. So this LH may also activate the premature meiotic process that damage the oocyte quality, and definitely that ultimately land up in formation of embryonic aneuploidies. In a normal cycle, only the dominant follicle responds to LH. We can also see here when a normal follicle is there, it can also lead to the formation of a dominant follicle at the end of day 14 or day 16. If the follicle, the response is LH is higher, so the response would be premature luteinization of the granulosa cells, that ultimately leads to arrest of the follicular development, that leads to the formation of necklace-like pattern in case of polycystic ovarian disease. So what happens if there is any, what is the role of GnRH or gonadotrophins if you are administered them in follicular induction? Definitely, we can expect a good result of change when we administer with gonadotrophins. We can just boost up the growth of the follicles because previously they are arrested with at the preandral levels. So if we administer them with either recombinant or purified FSH or LH, we can definitely see a change in the growth of the follicles. So what happens if we alter them at the level of pituitary, like kispeptins or neuropeptins? They play a key role in aspects of reproduction such as brain sex differentiation, puberty onset, gonadotrophin secretion, ovulation, and ultimately regulating the metabolism role in case of infertility. Kispeptins are a family of closely related peptides of different amino acid length that are encoded by KIS1 gene and operate through a G protein coupled receptor. Ovarian expression of KIS1 is under the positive control of the gonads. Local mediators also participate in the control of ovarian KIS1 expression. Inhibition of the prostaglandin synthesis, which causes ovulatory dysfunction, evokes a marked suppression of the ovarian KIS1 mRNA levels during the peri-ovulatory period. So what happens if inhibition of prostaglandin synthesis occurs? Definitely the expression of the ovariatrophins also will deprive. These observations suggest a potential role of locally produced KIS peptins in the control of ovulation. Whether alterations of such local actions of KIS peptins might contribute to the ovulatory dysfunction seen in PCOS warrants specific investigations. Definitely, these are all the area of research where one can expect a good amount of change if we're able to find out a result of any alteration in the gonadotrophin levels. Hyperandrogenemia is the most typical hormonal alteration of PCOS. Biochemically, hyperandrogenism is usually assessed by the assay of total testosterone, free testosterone, sex hormone binding globulin, androstenedione, and 17-hydroxyprogesterone and dihydroxyepiandrone sulfate. This biosynthesis of the androgen is generally mediated by the micro P50 chromosomal 17, which catalyze 1720 lyase activity. Any alteration in the 450 chromosome at the transcriptional and post-transcription levels has been implicated in the etiology of PCOS. We always know that any dysregulation or inhibition of the 1720 lyase activity with respect to the 17-hydroxylase has been found in women with PCOS. That leads to an increase in the 17-hydroxy ratio. Ultimately, the enzyme of the granulosa cells that convert the androgen into estrogen. So this leads to increased amount of estradiol. If you see in case of a PCOS woman, when they approach, we always ask them for hormonal parameters. When we look into it, obviously the estradiol will be either raised or either it fall into a normal category. But when we look into their hormonal patterns, we could able to appreciate definitely there is a rise in LH, or else it could be either normal. In most of the cases, in 60 to 70% of the cases, the LH will be raised, or else it should be normal in 15% of the cases. And what happens to the insulin? Definitely there would be a increase in insulin resistance happens. That was that is most promising in case of obese PCOS. If you generally do a C-peptide or insulin in case of women with obesity, you could appreciate there will be definitely insulin resistance. At the same time, we can also appreciate the sex hepatic binding globulin level that is much more decreased in case of PCOS. That's why those patients always present with acanthosis nigricans or those hirsutism, unwanted hairs over the chin, over the upper lip, and over the darkness over the neck area or over the thighs or in and around the groin. We could see all those male pattern changes since there is increased testosterone level, that is because of the unavailability of the sex hepatic binding globulin. These are all the hormonal changes we could appreciate in case of PCOS. Then coming to the insulin, as I said already, we always encounter a case of insulin resistance in almost all of the PCOS cases. So as I said already, 60 to 70% of the women with PCOS are obese or overweight. If you find out any factors contributing to the insulin, the action of insulin on the ovary uses the inositol glycan system as a signal mediator, a different mechanism from the system activated by the phosphorylation of the receptor at the tyrosine level in other tissues. An increase were observed in the urinary clearance of the inositol in some American and Greek women with PCOS. It reduces tissue availability of the inositol. This mechanism could contribute to the insulin resistance present in PCOS women. So coming to the insulin factors. So what are all the factors that influence the hyperandrogenism? It's nothing but IGF-1 and IGF-2. IGF-1 is a growth factor with endocrine function. It also has autocrine and paracrine function. So the many studies have shown increased availability of IGF-1 in thecal cell can also induce the increased production of androgens. So it induces, in fact, expression of the gene RH and release of gonadotrophins by the pituitary. So what is IGF? It's a multifunctional polypeptide with insulin-like activity that play important regulatory function and follicle and oocyte development. Circulating IGFs are produced by the liver. IGF-1 is secreted by the thecal cells, whereas IGF-2 is synthesized by the granulosa cells. The binding protein has been found in the follicular fluid and it is expressed by the granulosa and the thecal cells. So the follicular fluid IGF-1 levels in PCOS women are elevated than in normal women, which ultimately causes the arrest in the follicular growth. Then coming to the NGF, what is neurotrophin growth factor, is not only involved in the development of the nervous system, but also acts in the ovaries of humans and other mammals. It plays a fundamental role in the follicular genesis and oocyte maturation. This factor promotes nuclear and cytoplasmic maturation of the oocytes and process essential for the development of good quality oocytes and embryos. The elevated NGF concentration in the follicular fluid have been reported in women with PCOS. So coming to the transforming growth factor beta, AMH is a homodimeric glycoprotein that inhibits the development of the Mullerian duct in male embryos. It is expressed by the granulosa cells in the ovaries of the women of reproductive age, where it controls the formation of primary follicles and the follicular recruitment by FSH. It plays an important role in follicular genesis. Women with PCOS have higher serum and free fluid concentration of AMH when compared to the controls. This is closely correlated with greater development of the indel follicles and the arrest of the follicular growth. So coming to AMH, which is a very important, if we see AMH in any women with PCOS, we can come to a conclusion what is her follicular stage level or what is her natural follicular growth. When we start a patient for IVF, we always ask for AMH. Then only we can come to a conclusion of what is the actual reserve of the lady, actual ovarian reserve. So the high serum level AMH, the normal level of AMH is 1 to 3. If the level is above 3, in case of PCOS, if the level is less than 1, then we can call them as poor ovarian reserve. So the high serum level of AMH are directly correlated with an increase in the testosterone and the concentration in women with PCOS, as well as with altered oocyte maturation and low embryo quality. Further, elevated concentration of AMH in women with PCOS are correlated with higher percentage of immature oocytes and lower fertilization rate compared to women with endometriosis or pelvic adhesion syndrome. Activin and follistatin and inhibin are polypeptides which were originally isolated from the ovarian fluids. So this activin or follistatin, basically it's a binding protein which is produced by the ovarian granulosa cells. Cellular growth and differentiation is regulated by the autocrine and paracrine action. Overexpression of follistatin has been associated with arrest of the follicle growth and reduced oocyte development. So coming to activin, which is secreted by the smaller follicles. It promotes the follicle development by increasing granulosa cell response to FSH stimulation. It decreases the androgen synthesis and stimulates the oocyte maturation. Besides inhibiting FSH production, inhibins are produced by the dominant follicle and stimulate theca cells to produce androgens as substrate for estrogen formation. So increased follistatin or activin ratio and elevated concentration of inhibin B have been found in PCOS. So coming to VEGF, vascular endothelial growth factor. It's a homodynamic glycoprotein expressed in granulosa and theca cell and also present in the free fluid. So it plays an important role in angiogenesis, follicular vascularization, and intrafollicular oxygenation. It is therefore the impact of follicle maturation and oocyte quality, fertilization, and embryo development. The alteration of the follicular fluid concentration of VEGF in patient with PCOS is indicative of oocyte immaturity. The elevated concentration are useful as an indicator of oocyte maturity, successful fertilization, and embryo development in women with PCOS. So is there any role for interleukins? Recently, they have said interleukin 6 plays an important role in case of PCOS. So the interleukins are a group of cytokines produced by the leukocytes. In particular, interleukin 1, 2, 6, 8, 11, 12 play different role in regulation of folliculogenesis, ovulation, and corpus luteum function. The concentration of interleukin 12 in follicular fluid differ from immature follicle and those in pre-ovulatory phase and reduce. If you see the follicular fluid concentration of interleukin 12 and elevated follicular fluid concentration of interleukin 13 in patients with PCOS are correlated with reduced oocyte maturation, fertilization, and pregnancy. So what is the role of tumor necrosis factor? TNF-alpha is involved in the regulation of ovarian function, exerting an influence on proliferation, differentiation, follicle maturation, and steroidogenesis and apoptosis. TNF-alpha TNF-alpha is expressed by the oocyte, thecal cells, granulosa cells, and the corpus luteum in the ovary. Alteration in TNF-alpha levels in the follicular fluid are correlated to poor oocyte quality. Increased follicular fluid concentration of TNF-alpha in women with PCOS are also significantly inverse correlated to the follicular fluid concentration of estradiol, which indicative of poor oocyte and embryo quality. So is there any relation to FAS and FAS ligand? FAS ligand or membrane proteins belonging to the TNF subfamily, and they respectively have anti and pro-apoptotic functions. Concentration of FAS in follicular fluid are positively correlated with oocyte maturity. In women with PCOS treated with metformin, a reduction in the follicular fluid concentration of FAS ligand has been reported with the consequent increase in implant and pregnancy percentage. So, is there any role of vitamin D? Recently, they have said they have started prescribing vitamin D to each and every patient of PCOS. Of course, they could appreciate a smaller change, those with administration of vitamin D and melatonin, because melatonin is something that alters the leptin. As I previously said, there is leptin resistance in patients with PCOS. So, if you administer with vitamin D or leptin, you can definitely achieve a smaller change in the amount of ovulation, and ultimately you can land up in getting a clinical pregnancy. So vitamin D is an essential regulator of bone and mineral homeostasis. The recent studies have demonstrated hypovitaminosis D is associated with an increased likelihood of developing metabolic disorders. So vitamin D deficiency has also been demonstrated in patients with PCOS. Obese patients with PCOS have also been shown to have lower serum levels of 25-hydroxy than non-obese men with PCOS. Vitamin D deficiency has been suggested to have a role in the development of insulin resistance and impaired glucose tolerance in such patients. So, coming to the conclusions, PCOS is not only a reproductive pathology but also a definite systemic condition, and its etiopathogenesis is still not completely understood. So many molecular and epigenetic formulations are there. When we want to understand the complete genetic formulations, we can just go through a recent research articles which talks much about the epigenetic formulations and the interleukins and the cytogenetics, what does it do, and what are all the various level of alteration in the metabolic pathways that alter the way that causes metabolic derangements in case of PCOS. We can get into an idea of that. So a recent approach of the clinical practice has been improved towards the prevention together with the standardization of the treatment protocols for the diseases. Therapeutic tools are represented by the hormonal contraceptives, anti-androgen drugs, insulin sensitizers like metformin and inositol. Of course, I just want to mention a few points about metformin. Previously, we didn't go for metformin. Nowadays, many people I have started various prescriptions. People have started using metformin in case of according to the BMI. If the BMI is high or if the patient is overweight or obese, of course, you can use metformin 850 mg BD for 12 weeks. If the woman is lean, you can start them with metformin 500 mg OD for 12 weeks. Of course, metformin has an important role in regulating the ovulation, and also it aids in weight loss. So in PCOS, it's the early diagnosis and the treatment can prevent or delay its typical long-term sequelae. Yeah, that's the end. Thank you so much for giving me this opportunity. Thank you
so much, ma'am, for giving the detailed information regarding the recent updates on PCOS. So let me check if we have any queries in the comment section. Give me 1 minute, ma'am. So, ma'am, there is one question that does the genetic material also impact to cause PCOS?
Actually, a theory is there which states that any genetic alterations, like what I said in case of diabetes, we say no, there is some genetic correlation. Like that, PCOS has also a genetic correlation in terms of fetal ovary itself, it starts. If there is any alteration in genetic level, it might lead to the development of PCOS in future. Definitely, if PCOS develops in future, it has long-term sequelae in case of development of any metabolic derangements, such as developing cholesterol disorders or developing diabetes in future, or complicating an ongoing pregnancy. Yes, there is a role.
And the second question is, do you find myo-inositol helpful in PCOS?
Actually, myo-inositol is a supplement. Honestly speaking, we
Yeah.
can't expect much change while in case of myo-inositol or D-chironositol. Even if you supplement them with 2 grams of myo-inositol, honestly, I can't see a much difference. It's just a supplement. That's all. Yeah.
And what diet do you recommend to your adolescent PCOS patient?
Yeah, the first and foremost thing what I advise is lifestyle modification. Yes, I'll just if an young woman or young girl comes to me with PCOS, I'll just ask them their diet. That's my routine. So I'll just inquire what and all food they are including, whether it's junk or most of any stress might be working in IT companies. So I'll just ask them or advise them to change their diet pattern and include some basic exercise, yoga, meditation, and just add them to I'll ask them to have more antioxidant based food rather than having more junks, because if you cut off any cholesterol or either junks or more carb based diet, definitely you can see regulation of their menstrual cycles in 50% of the women that I have so many young girls with lean PCOS who have achieved menstruation or who have achieved ovulation on a diet basis itself. Okay, so what I advise them is to go for a lifestyle modification, to go for weight loss, to go for diet habitary patterns, then also along with some supplements like as I said, myo-inositol or chironositol. I have added calcium, I have added metformin for obese patients. I will also advise them iron supplements. In case of if I found them to be anemic, I'll add iron also. Yeah.
Okay, ma'am. Thank you for giving all the answers to the questions, and we are glad to have you on our platform. And we would like to have more sessions with you in future upcoming
Yeah.
sessions.
Thank you. Thank you. Thank you
Thank
so
you
much.
so